QRS duration more than 120 milliseconds. Then northwest axis, AVR is positive. Then absent P waves. Okay, that can happen in AVF also. Anything else? Ventricular origin of the QRS. RSR pattern. Yes, it is an RBB morphology of ventricular rhythm. Anything else? V5, V6 has a QS morphology, which is suggestive of a ventricular origin. So we know that this is a ventricular origin rhythm and no P waves are there. So this is a typical AIVR we see after revascularization. Kindly note that the presence of an AIVR does not necessarily mean that the patient is fully revascularized. But once we revascularize a patient in cath lab and see the patient developing AIVR, then we put the diagnosis as yes, it's an AIVR reperfusion related. But sometimes even totally occluded arteries also can have AIVR and doesn't necessarily mean reperfusion. Now questions. Is it stable rhythm? Anybody can answer. Medicine PGs. Yes. Why? Because this one, the rate is between 60 to 100. VT becomes extremely unstable when the rate is very high. So it's a stable rhythm. Is it good? Yes, it is good, provided this is a true reperfusion arrhythmia and not just another arrhythmia related to the MI. What is the mechanism? Medicine PGs? Medicine PGs are there? Final years, can you raise your hand? Okay, the mechanism is automaticity. Why is it called AIVR? It's accelerated because the ventricular rhythm is usually around 40 per minute, whereas this one will have a rate of around 80 to 100 and it's accelerated. So it's accelerated idioventricular rhythm. Where is the focus? Sir was telling before, it has RBB morphology. So it's from LV. There is the reciprocal rule of bundle branch block pattern that we know. So if it is from the LV, it will have RBB morphology. It's from RV, it will have LBB morphology. Whereas if it is from the septum, it can have either LBB or RBB morphology. How does it start? Does it start with an escape beat or an ectopic beat? Any guesses? Yes. AIVR starts with an escape beat, whereas a VT starts with an ectopic beat. And is it more common in inferior posterior MI or an anterior wall MI? Yes, very often there are quite a few others who believe that it is more common with inferior posterior MI, but it's almost as equal with an inferior posterior or an anterior wall MI. Patients with prolonged AIVR, of course we know it's a stable rhythm. If the patient has a few seconds of AIVR, we are not bothered. Do not give antiarrhythmics, do not cardiovert, as long as the patient is hemodynamically stable, which most commonly they are. But then if the patient is in prolonged AIVR, couple of hours, what do we do? It's not good to have ventricular focus for quite a long time because sometimes it can lead to myocardial suppression and loss of AV synchrony. So we try to achieve the AV synchrony and activate the sinus node most commonly with 2 ampules of atropine and then a flush. Very often the sinus node will be activated, the sinus node rate will pick up and the heart rate will go up above 80, which is most commonly faster than this AIVR, and the normal sequence of events is restored. So atropine is the treatment. Thank you.
Thank you, sir.
I request Dr. Yogesh, Assistant Professor, Father Muller Medical College, to present a certificate of appreciation to Dr. Tom Devasya. Thank you, sir. The next talk will be conducted by Dr. R.L. Kamath, Chief Interventional Cardiologist, KMC Mangalore, on the topic Brugada and long QTC. Dr. R.L. Kamath.
Good evening, ladies and gentlemen. After a long section, let me go a little deviate from my talk by applying some clinical knowledge to the ECG. That becomes easy because talking to the rare, ECG changes of Brugada and long QT is boring. A 30-year-old man comes to the emergency room following an episode of syncope. His wife says, he was perfectly all right, doctor. He was watching a TV, collapsed half a minute, and then he became all right. He comes to the casualty. The ECG was taken. BP, everything is stable. Clinical examination is normal. The duty doctor says, sir, this patient is normal except a right bundle branch block. He has nothing. Absolutely normal. Then I said, okay, admit him. Send one cardiac enzymes. Report comes normal. He does an echo, no regional wall motion abnormality, absolutely normal. But then we kept him in the hospital. We don't know the cause of syncope. Next morning he says, I'm only 30, I'm going. Fine. Trop test is negative, echo is normal. So, as he was about to shift from the ICU to the room, collapsed, pulseless, BP unrecordable. What do you think is the problem? Immediate DC shock was given, ventricular fibrillation was diagnosed, cardiac monitoring done, and instantly improved. A person has a normal heart clinically, normal echo, documented ventricular fibrillation in the ICU, preceded by a syncope. What is the diagnosis? This RBB is not a simple RBB. You watch that. This is a very peculiar RBBB. Peculiar. You can see here. This is what is called as Brugada syndrome. Brugada. They are the three brothers who in 1991 diagnosed this condition, where it was published in 1992, and this goes by their name, three brothers who are cardiologists and Brugada. You can see this. There are two types, type 1 pattern. You see, this is lead V1, ST elevation, and this is another type in lead V1. Now, what is the danger of this? When you said structurally normal heart, nothing on examination, these are the possibilities. They are all rare condition. Intermittent congenital or drug-induced long QT syndrome, ventricular fibrillation, catecholamine sensitive polymorphic ventricular tachycardia, sudden coronary spasm, arrhythmogenic right ventricle, and of course, last the Brugada syndrome. I kept last because very uncommon in this part, though we have seen about a dozen patients in the last 10 years. Now, somebody asked coronary spasm. The marked ST elevation, within half an hour the ST segment has become normal. Is it an MI? I'm telling you, in the present scenario, this you can immediately say, if you have an echo machine in the ICU or in the casualty, it's a 1 minute job. It's only 1 minute. If you have marked ST elevation, do an echo. If it is marked infarction, coronary spasm, there should be not 99, 100% regional wall motion abnormality, 100%. Coronary spasm is relieved, spasm goes normal pumping, means you can see the value of echocardiogram in the casualty or in the ICU. Instant, it takes only 1 minute, put the probe, do the long axis, short axis, normal pumping, no myocardial infarction. can have ST elevation, regression. Invariably they will have spasm during the coronary, ST elevation, marked ST elevations. They will have pain. This patient whom I said had no pain. So coronary spasm is out. There are only two possibilities: arrhythmogenic right ventricular Brugada. The ECG is classic of Brugada. Now what is this condition? I am not going to highlight too much on the molecular or the genetic reason for this Brugada. The problem is, it is for you to identify who is Brugada. What Brugada syndrome, because it runs in families. And why it is dangerous? It is dangerous because he can have a syncope, he can have polymorphic ventricular tachycardia, he can have sudden death, and that is the reason why you should diagnose Brugada. Very common in Thailand, Southeast Asian countries. Several members of the same family below the age of 40, when they die suddenly, think of Brugada. In India, our study shows it's uncommon. But many people need not have all the typical features of the ST elevation or anything. But if you strongly suspect Brugada syndrome, and you have the typical ECG, check for the family members, and if they don't have the typical changes, you can make, or you can make the ECG changes of Brugada syndrome by giving either injection ajamalene or flecainide intravenously, and you can reproduce the ECG changes of Brugada in people who have partial penetrance or some genes he carries of Brugada. You can make it, and these are all high risk cases. But then what to do for this type of Brugada syndrome? What to do? We have no idea. Possibly we must ask Dr. Green here, who is sitting here from Canada. He may give some answer for Brugada. Often when you have Brugada syndrome like this, the case which I said, collapsed ventricular fibrillation, you have no medicines available to you to help him. He requires probably an ICD implantation, internal defibrillators to be implanted, because we have no other choice left. Can I, if a Brugada syndrome patient you are detected, can I do EP study and find out whether he is a high risk case? Maybe 20%. So majority of the electrophysiologist will attempt, but final, no. I am not very sure. What about Green? What do you think? Is the EP study you do in all cases of Brugada if they are asymptomatic?
We don't use EP study for...
Exactly. There are certain people who do EP studies to find out whether he is the candidate for sudden death. Whether not many people do it, as Green said, but I agree with him. But what to do if there is a family history of sudden death? And if the patient has sudden history of syncope, there is no point in wasting time. You advise him straight away. These are all various criteria given. It is only for electrophysiologists to apply these things. Your aim should be, once you detect Brugada, see whether he is a case for, based on the history which is available, family history and family history of sudden death and history of previous, straight away send him for electrophysiologist. I am not an electrophysiologist, but you can warn the family that he will always have the risk of dying suddenly due to ventricular fibrillation and ventricular tachycardia. Now, that's only as far as Brugada is concerned. Let me go to the next topic, long QT. This also, here also I'll give a short case history. This is very helpful for physicians as well as the the PGs here, how to arrive at a diagnosis and what clinical situation you can think of long QT. We have a 36-year-old lady who had a elective cesarean. When I say elective cesarean, presumably she is all right. She has been fully evaluated, pre-anesthetic, perfectly all right. 7th day discharge, happy. 10th day returns with the fever, and the relation said one fit she had. Fine. Chest X-ray shows a small pneumolytic patch. She has a pneumonia, admitted. In the casualty, one more fit. She was seen by a practitioner and he had put her on moxicillin, and she was all right. But then fit was dangerous, post-operative, admitted. 2 days later, she had a fit in the room. No reason, shifted for MRI of the head. While shifting to the MRI, at the entrance, cardiac arrest. One fit, cardiac arrest. No pulse, no BP. Most of the cases in KMC, when we transfer from, we have a oxygen monitor, everything ready. And in the MRI, we have a defibrillator. Monitor shows. You see what it is? It is ventricular fibrillation. Ventricular fibrillation. Luckily, radiologists, all are ready. Gave a DC shock. DC shock. See the second one, what happened? You see, we have the P waves, no QRS. All the P waves are there, QRS is not there. Ventricular standstill. Last one, it has picked up. You can see the last one. What is happening, man? It is also having some standstill here. Anyway, picked up. So, the recovery is instant after the DC shock. Ventricular fibrillation is documented. DC shock given, recovered completely. In the meantime, intubation was also done. Within 3 or 4 minutes, extubated, patients fully conscious. The nurse has taken blood for routine investigation. Potassium comes as 2.7. Fine. What is it? Now, so this is the ECG, one strip I am showing you. This lower ECG was a ECG taken when she was admitted, and the upper one immediately after the cardiac arrest. What do you see here? You see the top one is after the cardiac arrest. The top one shows classic QT prolongation. The lower one, QT is almost normalized. So what was the diagnosis? In the beginning, when the patient had a fit, the diagnosis offered in a post-operative pregnant lady, drug-induced reduction of Scheizer's threshold by moxifloxacin, maybe a intracranial venous thrombosis, it may be an eclampsia, or it may be an epilepsy. The diagnosis is long QT. She had ventricular fibrillation, ventricular tachycardia, cardiac arrest, and she was about to die. Thanks, she was in the hospital. Otherwise, what is the reason for that? Long QT is responsible for what? For the arrhythmias. It could be either congenital or acquired. In this patient, is it congenital or acquired? Most likely it is acquired. She may be having some genes. There are some 250 mutations, the genes which can give rise to long QT. So we really don't know to study their gene pattern and molecular pattern, because there are very few centers, even in United States, there are very few places where you can do the gene study But as far as we are concerned, this patient has a long QT, documented ventricular fibrillation, DC shock given. Now, what is the reason for this long QT? This lady, she was on Moxa. 2, she had a hypokalemia. Both are notorious in giving rise to the long QT. I said long QT, dangerous thing. It can give rise to syncope. Syncope can give rise to fits, ventricular tachycardia, ventricular fibrillation, and what is called as torsade de points. A torsade. French people say torsade. We don't say torsade de points. They say torsade de points. It's a French word. So we call it as torsade. We are neither French nor British. We say torsade. Torsade. Easy. Now, both congenital ones are very rare. This is called Romana, and it is Jarvel. Jarvel is often associated with the deafness. Pediatricians know, most of them they present during the younger age, 10 to 15. And acquired is due to so many conditions. I am just giving you this because this is all mostly theoretical for postgraduates to know. But since in a given short 15 minutes of time for me, I thought it is better to give 2 case histories and show you the typical ECGs so that you can now detect in both the cases Brugada as well as long QT. It is the physician's role to identify the case and execute what is to be done. Now your level is, now for congenital QT, what will I do? This is a defect is in the channels, the sodium and potassium channels in the cell. Sodium is loaded in the cells. Some of the cases, they die during exercise. Some of the cases, interestingly, they develop a VT or polymorphic when they hear some strange loud noise. Let us say it's a silent room